So this is a very interesting time because the immune checkpoint inhibitors have recently been assessed in renal cell, and of course nivolumab is basically approved in the second line setting right now for renal cell, but there was recently a randomized trial of ipilimumab and nivolumab versus sunitinib, which showed a benefit in overall survival as well as in response rate in patients who received the ipilimumab nivolumab. So the general feeling is that the immune checkpoint inhibitors are going to be incorporated into the first line setting, and patients do want these trials. The perception, or these treatments, the perception is that a lot of the immune checkpoint inhibitor therapy in the majority of patients does not have a lot in the way of side effects. But I think figuring out which patients benefit from immune checkpoint inhibitor therapy is less well defined. Certainly patients who have poorer risk, more aggressive disease seem to benefit, especially to the immune checkpoint inhibitor trials. So I think that as far as the sequencing of these drugs, there's going to be a group of patients that perhaps have very rapidly progressive disease that you may not want to put on an immune checkpoint inhibitor, like if their life expectancy is less than 3 months. And for that group, a VEGF TKI is probably a better drug to choose. And people who have very slow growing indolent disease, maybe you want to just follow those patients for a while and not put them on either therapy. So I think the perceived sequence is going to be either immune checkpoint inhibitor or VEGF TKI in the first space, same for the second, and then thereafter it's probably going to be more in the range of VEGF tyrosine kinase inhibitors.